So from 14 we have to do it now.
Yes,
Yes.
sir.
Yes, welcome to the student for the part 2 discussion, and we'll see that how a plain X-ray, just X-ray helped before, and now how we'll see. Can start.
Yes, sir. A retrosternal thyroid goiter may be apparent on the chest radiograph as a superior mediastinal mass which displaces or narrows the trachea. The trachea may also become stenotic following percutaneous tracheostomy insertion. Although additional thoracic inlet views can be acquired to further assess the degree of narrowing, evaluation with multiplanar computed tomography, respiratory flow volume loops have been shown to be more sensitive than the plain films.
So as you could see in this, like your retrosternal thyroid is very important one. The retrosternal thyroid one you should be keeping in mind. So every time you have to pose a question mark whenever you have got retrosternal thyroid extension. Especially chest radiograph can be used, number one, as a superior mediastinal mass which displaces or narrows the trachea. Tracheal narrowing you should be keeping in mind. And trachea becomes stenotic following percutaneous tracheostomy insertion. So regular tracheostomy is a bit better than this because stenosis occurs because of this percutaneous tracheostomy. And thoracic inlet views are the one which are useful for seeing the assessment of the narrowing and evaluation of multiplanar uh, computerized tomography. So multiplanar computerized tomography is a good option to see the narrowing of the trachea, and you have to see with the respiratory flow loops also. Respiratory flow loops which are more sensitive than plain films. So better is number one MDCT, this multiplanar CT scan. Second one is respiratory flow loop, and the third one is your plain film. So last priority gets to plain film. Keep it in mind, all those things. So next,
An orthopantogram is often performed to assess the dentition. It also evaluates periodontal pathology and focal mandibular lesions. In patients with oral cancers, particularly those located in the retromolar trigone, it can be useful to assess the extent of mandibular bone involvement. However, thin section CT is superior for confirming subtle bone destruction.
and you could see here in this particular thing, very importantly, orthopantomogram. As we have already seen that picture, orthopantomogram. You've seen the picture in the previous discussion, and in that, especially when you have mandibular lesions, the periodontal pathology, periodontal, that is around the, if this is a tooth, and then periodontal pathology can be seen. We've seen in the other pantomogram before. And oral cancers, you have to go for, especially in the retromolar trigone region. So what is retromolar trigone region? One which is behind is the anterior pillar. From the anterior pillar, and then you could see the lateral most part wherever the buccal ends. So this is the retromolar trigone, triangular region called as retromolar trigone region. It helps in the assessment of mandible involvement. And other than this OPG, you have got something called as CT scan, which is more helpful for bone destruction. Any destruction of the bone, CT scan will be helpful. So you can keep in mind about all these things, and then you can proceed forward.
Contrast studies for fluoroscopy. The barium swallow examines the esophagus. Double contrast films are used to demonstrate morphology and mucosal lesions, and the addition of bread to the barium allows assessment of motility. Isotonic iodinated water soluble contrast agent should be used in preference to barium when aspiration is present or suspected, or when the anastomosis are being assessed post-operatively, since barium aspiration can be fatal.
So once again, you should keep in mind about this contrast study, very important fluoroscopic study. This is called as fluoroscopy, wherein this barium swallow helps in the examination of esophagus. As you could see, that rat tail appearance or achalasia cardia, bird beak appearance, all these things will be there in barium swallow only. Next, double contrast films. So two times contrast is given to demonstrate the morphology, number one. Number two is mucosa. Okay, mucosa, and also motility. What are the 3 M's that are assessed? Morphology, mucosa, and motility. Morphology, mucosa, and motility. These all should be kept in mind. These all should be kept in mind. And you should have isotonic, iodinated, water soluble contrast agent. Isotonic, iodinated, water soluble contrast agent. It is always better than barium. So barium, other than this, isotonic, iodinated, water soluble contrast is useful whenever there is aspiration which is possible, or aspiration that is suspected. If you have a doubt, it's better to go for isotonic, iodinated, water soluble contrast agent. So when anastomosis, even when anastomosis, for anastomosis also, barium aspiration is always a chance. So it can be a fatal one. Therefore, they go for isotonic, iodinated, water soluble contrast agents. So based on this, you can understand what is the need for fluoroscopy.
The pharynx and upper esophagus are examined using video fluoroscopy or cine fluoroscopy. Contrast examinations to evaluate the act of swallowing by analyzing the following features.
So pharynx can be evaluated by video fluoroscopy and cine fluoroscopy. Video fluoroscopy and cine fluoroscopy very important, as we know that. So number 1 is video fluoroscopy. Number 2 is cine fluoroscopy. It's just like a movie that you can see what is happening in the upper pharynx and upper esophagus and pharynx. So next one is, as we already seen, isotonic iodinated contrast. Number 1, number 2 is the barium that you have seen. So those both are also helpful. Those both are also helpful for doing the things. And which will be helpful for number 1, tongue movement, soft palate elevation. So tongue movement, soft palate elevation. Number 1 is tongue movement. As you could see here, is tongue movement. As you could see how the tongue is moving within the this mouth oral cavity. How is it moving? Next is soft palate elevation. Soft palate elevation. Number 3 is epiglottic tilt. Epiglottic tilt. When you see here, this is the epiglottis. What is the epiglottic tilt? Number 4 is laryngeal closure. Whether it is closing or not, this is the larynx. That is the laryngeal closure. So supraglottis, glottis and subglottis region. Whether laryngeal closure is okay, this movement is okay or not, you will be able to see. Next, number 5 is pharyngoesophageal segment, especially the cricopharyngeal opening. So after going here, the foot goes to level C6 level vertebra. It goes to pharyngoesophageal junction, and pharyngeal peristalsis. All these things can be evaluated by this, the one which we have seen previously. So you could see, so following features with the help of contrast evaluation. Next.
To evaluate the act of swallowing by analyzing the following features: tongue movement, soft palate elevation, epiglottic tilt, laryngeal closure, pharyngoesophageal segment, and the pharyngeal peristalsis.
So we already done this. Next.
Malignant pharyngeal and esophageal tumors can be diagnosed by their irregular narrowing of the lumen with mucosal destruction, ulceration, and shouldering. The length of the tumor can be measured, which is important for staging the hypopharyngeal tumors and planning operative intervention for possible free jejunal transfer as well as radiotherapy field planning. Previous radiotherapy, caustic ingestion, and connective tissue disorders can cause smooth esophageal narrowing.
So as you could see here, once again, this pharyngeal and esophageal tumors, you should keep it in mind. They are diagnosed by the irregular narrowing, that is the rat tail appearance of the lumen. And you should see for the mucosal destruction, see for the ulceration and shouldering. So these are the very important words that every ENT student should be knowing that. So what is the malignancy showing? Number 1, irregular narrowing. Irregular narrowing. This is irregular narrowing. Next, lumen with mucosal destruction. Mucosa will be destroyed. Number 2 is the mucosal destruction. Number 3 is ulceration. Ulceration. Number 4 is shouldering. Ulceration. Number 4 is shouldering. You should keep it in mind about the shouldering, ulceration and shouldering. That is something like a shoulder that is going to be formed over here, shouldering. Okay. The length of the tumor can be measured for staging the hypopharyngeal cancers and planning operative information for free jejunal transfer, as well as radiotherapy field planning. So in hypopharyngeal tumors, which includes pyriform fossa, post-cricoid region, okay, posterior pharyngeal wall, all these things. So you have to go for free jejunal transfer. It is one of the surgery that is being done, and you will be doing the radiotherapy also for field planning. And previous history of radiotherapy and previous history of caustic injection, previous history of connective tissue disorders, and smooth esophageal narrowing can be there. So all these things can cause smooth esophageal narrowing, whereas malignancy can cause the stricture, shouldering, ulceration, mucosal abnormalities. This previous history of radiotherapy and caustic injection, they cause smooth narrowing, so which is a different thing from all the other structures. And ultrasound, now we are going to see the ultrasound.
Ul- Ultrasound is an imaging modality utilizing high frequency sound. The probes contain piezoelectric crystals which generate pulse beam of sound in response to either mechanical or electrical stimuli. The crystals also receive the reflected beam which has been attenuated and refracted by the tissue interfaces.
So in ultrasound, as you could see here, very importantly, you have something called as piezoelectric crystals. Piezoelectric crystals. So piezoelectric crystals, which will help us in imaging the things and utilizing the high frequency sound. So you have the name itself sound, so high frequency sound. The frequency is very high and you have that sound. The probes, as you know, the probes that are there, like, hammer shape or something like that, the transducers, they are called as transducers. They contain a lot of piezoelectric crystals. You can say PEC. So PEC, that is piezoelectric crystals. So piezoelectric crystals, they generate beams of sound and in response to either mechanical or electrical stimuli. So mechanical and electrical stimuli. So they respond for, you should remember that PEC. PEC is responding for me. That is mechanical and electrical stimuli. That way you can remember this mechanical and electrical stimuli. And the crystals also receive the reflected beam. So the reflected beam, whatever the beam that is going outside and reflected beam, they receive that, which is attenuated and refracted by tissue interfaces. So there is one thing called as attenuation. Number one, first point called as attenuation, that is decrease. Number two is refraction. Refraction. These are all the concepts behind the ultrasound. Number three is reflection. So reflection. So you could see number one attenuation, number two refract, and number three is reflected beam. All these are done by the PEC. So that is your simple piezoelectric crystals. Piezoelectric crystals.
Recent development in technology, particularly the evolution of high resolution US ultrasound, has resulted in a greater role for ultrasound in evaluating the neck. Ultrasound is ideal for examining superficial structures in the neck, but due to attenuation of the sound beam as it passes through the tissues, examination of large necks and deep structures such as the deep lobe of the parotid is more difficult.
So as you could see, once again, because of the development in the technology, you should keep it in mind. So evaluation of high resolution, always HR is not human resources, it is high resolution ultrasound, and it is a greater role for evaluating the neck. Neck is evaluated by this HR ultrasound. So ultrasound is ideal for examining the superficial structures, especially the superficial structures of the neck. Superficial structures of the neck. And once again, we got the word called as attenuation here. Attenuation of the sound beam. It passes through the tissues, and you can have the examination of large necks and deep structures, such as deep lobe of the parotid, which is more difficult. So superficial structures, when you say this is a neck, the superficial structures are very easy because attenuation is less, but the deep structures, it is very difficult to see in the ultrasound. Superficial structures can be diagnosed very easily in ultrasound. That is one point. That is one point which you should keep it in mind. So once you see that,
In addition, the ultrasound beam will not readily penetrate the bone, cartilage, and gas, making it an inappropriate technique for local staging of many primary head and neck cancers.
so when you take this one, like as you could see here, uh, ultrasound beam will not readily penetrate the bone. Bone, it is not useful. Cartilage, it is not useful. And gas also, it is not very useful, like in the lungs. So bone, cartilage, gas are not at all useful. So it is an inappropriate technique for local staging of many primary head and neck cancers. You cannot stage with ultrasound. You can just only see things. Staging cannot be done with ultrasound because bone is not at all helpful. Cartilage is not at all helpful. Gas is not at all helpful. So when it is so, then how can we stage all the things? Okay. In that manner, you should be keeping in mind that it is not very helpful, but it is helpful for some amount of superficial structures notification.
Ultrasound is extremely useful in differentiating solid from cystic mass lesions, and it can detect calcification. An assessment can be made of the size, margin, and consistency of a neck mass. Evaluation of the internal structure and the margins of the neck nodes will facilitate differentiation between benign and malignant nodes.
So keep in mind, extremely useful. The most important thing, that is solid tumor or cystic tumor. There is a thyroid solid mass or a cystic mass, as you could remember that. And it can detect the calcification also. Very important, any calcium, calcium, calcium. So imagine that calcifications can be detected. It's not the bone completely. The calcification that can be detected very properly. And assessment can be made based on the size, number one, margin, number two, consistency, number three, size, margin, and consistency of the neck mass, and evaluation of the internal structures and the margins of the neck nodes. So margins of the neck nodes, you could see that margins are there or not. It can help in knowing whether it is benign or a malignant one, whether it is a benign or malignant one. All these things can be helped with the help of ultrasound. Bone, cartilage, gas cannot be seen, as you could know that the previous slide. So in this particular thing, once again, you could see the angle of the mandible. So I'm trying to say that orthopantomogram, local erosion of the alveolar surface of the left angle of the mandible due to squamous cell carcinoma. Of course, this is not related to ultrasound, but this is one picture that came, so I'm trying to explain it here. So local, you could see that here, you could see the local erosion of the alveolar surface of the left angle of the mandible. Local erosion of the alveolar surface of the left angle of mandible, that you could see over here in this particular thing. So in this particular thing, you could see the local erosion as far as possible. Ultrasound, once again, if you are able to see here the ultrasound image showing a metallic needle. So as you could see here, position within the necrotic level 1 node. So this is that you are going to do the ultrasound with the help of FNAC, with the help of ultrasound. FNAC, ultrasound guided FNAC. You could see in these arrows that ultrasound guided FNAC. Next.
Color flow and Doppler ultrasound can be used to evaluate the vessels within the neck, the relationship of SS to the major vascular structures, and also the vascularity within masses and neck nodes. The accuracy of core biopsy and fine needle aspiration cytology of small neck masses and nodes is improved with ultrasound guidance, as the metallic needles are clearly seen passing through the subcutaneous tissue into the lesion or the node.
So as you could see here in this, once again, color flow and Doppler ultrasound. Doppler color flow. Doppler will be helping us to see the vessels. Number one, vessels you should be keeping in mind. The relationship of to assess to the major um, vascular structures. To see the major vascular structures. Major vascular structures also you should see. You should see the vascularity of the tumor within the masses and also neck nodes. So vascularity of the tumor can be seen, and also the neck nodes. So you can see the neck nodes also within the masses. Vascularity can be seen, and within the next nodes also you can see that. And the core biopsy, as you could see, core means you have to see if take from the center, that is core. So, and the fine needle aspiration cytology of the neck, small neck masses. The small neck masses and nodes is improved with ultrasound guidance. You have to always do it with USG guided. So USG guided. So you have to go for USG guided USG guided FNAC or USG guided core biopsy, etc. As you could see here, as the metallic needles, as you could see here, are clearly seen passing through subcutaneous tissues. The particular previous picture, as I have already shown that. So metallic needle in the previous picture is already shown in the same picture, as you could see the arrows again, once again. Next, we are going to go for the computerized tomography.
Computed tomography uses ionizing radiation. It has evolved significantly since its inception in 1972. Spiral CT scanners which use a single rotating X-ray tube.
So very importantly, computerized tomography, it is from 1972. So it is using ionizing radiation. It is using like a X-ray only. Tomo means cutting, dissection, anatomy, like something like that. And computed, that is computer related pictures are taken in different slices, and they are, they are made into organization as if, they are related to each other, so that complete body scan can be done. So now spiral CT scanners, single rotating X-ray tubes are also present. Spiral CT scanners with single rotating X-ray tube are also present. So next is about
Complementary series of rotating X-ray detectors are now being replaced by multi-slice helical scanners, also known as multi-row detector computed tomography scanners. MDCT scanners use revolving X-ray tubes and a multiple row detector array that simultaneously acquires a series of 4, 16, 32, and currently 64 slices. Images are acquired while the patient passes through the gantry, providing a three-dimensional volume block of data.
so what you have here is a complementary series, complement each other. It is a series, as you could see. For example, this is a patient from top to bottom. You have got a series order one after the other. So rotating X-ray detectors. You have got a lot of X-ray detectors inside, and they are now replaced by multi-slice helical scanners. So multi-slice helical means helix, something like a cochlea, as you could see. Multi-slice helical scanners, they are known as multi-row detector. It is called as multi-row detector computerized tomography scanners. So multi-row detector computerized tomography scanners. MDCT is multi-row detector CT scanners are using revolving X-ray tubes, and they have got the revolving X-ray tubes like this, and multiple row detector array that simultaneously acquire a series of 4, 16, 32, and now 64 slices, and more than that also 128 slices also. So images are acquired when the patient passes through the gantry. So wherever the hole is there, a tube like thing, something like that, patient will be passing inside like this. That is what is called as gantry. It's called as gantry, and three-dimensional volume block of the data. You will get a three-dimensional volume block of data. So that is one thing which is seen over here.
Although images are usually acquired axially, multi-slice scanning enables the radiologist to manipulate the data to produce both thin section images and multiplanar reformats. As images are more rapidly acquired, there is decreased movement and respiratory artifact.
So you should keep it in mind about these things also. So keep it in mind about these things also. So when you have that, you can just take multi-slice scanning. So images are acquired axially. So I already told you this is the patient. That means axially a lot of images are acquired. Multi-slice enables the radiologist to manipulate the data and produce both thin section images and multiplanar reformats. So number one is thin section. Number two is multiplanar reformatting. Multiplanar reformatting. As images are more rapidly acquired, they are very rapid. It's not like unlike an MRI in 2 minutes, CT scan will be over. And the decreased movement will be there. and respiratory artifact will not be there. So decreased movement will be there and respiratory artifact will not be there. Yes.
In addition to potentially inducing a new cancer, exposure to a cumulative high dose of ionizing radiation can induce cataracts within the lens of the eye. Therefore, unless relevant to the examination, the orbits should be excluded from the CT.
So as you could find it over here, like you should have a constant thought process that lens of the eye might get damaged. So cataracts might be formed. A high dose might be given to that. So it can induce a cancer. It can induce a cancer. Therefore, orbit should be excluded from the CT scan. Don't send the orbits inside the CT scan. Orbit should be excluded from the CT scan. Orbit should be excluded from the CT scan. That should be kept in mind.
Axial images are acquired with the patient lying supine. Direct coronal images can be obtained if the patient lies prone with the neck extended. This position can be uncomfortable and has been replaced in most centers by the use of MDCT with coronal reformats. The larynx is optimally assessed with images reformatted to the plane of the vocal cords. Reformats can also aid assessment when there is artifact from the dental amalgam.
So as you should keep it in mind, like this multi-directional multi-detector, as we have already seen, axial images can be obtained when the patient is in supine. So this supine position will help us to see the axial images, number one. Coronal images, you want to see if the patient is prone. So when the patient is prone like this, with the eyes like this and then head like this, you can get the coronal images. But next neck has to be extended. So this is not a feasible one. Therefore, most of the centers they are having multi-directional CT scans with coronal reformats. Coronal reformats that itself will reformat everything, and you could see that. So next is larynx is optimally assessed with images reformatted. That is called as reformatting. You just remember this word, reformatted. So reformatted is the one which is very much useful for us in the plane of the vocal cords. That is where larynx images can be got like that. And reformats, they will be helpful in the assessment of artifacts. So you can also avoid the artifacts from dental amalgam, especially in this oral cavity related ones. You can go for dental amalgam. So you can just avoid that also, and by that manner you can go for that avoidance of that.
The administration of an iodinated contrast medium results in vascular opacification, enhancement, and increased conspicuity of the primary tumor and rim enhancement in pathological nodes. There is a small risk of reaction to the contrast media, including nausea, urticaria, and bronchospasm, but patient rarely develop serious long-term sequelae. Anaphylactoid reactions and death as a consequence are also rarely seen.
So as you could see, very importantly, you should have in mind about this iodinated contrast. Very importantly, iodinated contrast. We already seen that. So iodinated contrast, very important. It can help us in vascular opacification that you could see. This is called a CECT. Vascular opacification and enhancement and conspicuousness of the primary tumor. The tumor is enhanced with this particular thing. This is conspicuousness of the primary tumor, and it is also called the rim enhancement of the nodes, pathological nodes. These lymph nodes, there is a rim enhancement of these lymph nodes also. Rim enhancement of these lymph nodes, rim enhancement of these lymph nodes, very importantly, rim enhancement of these lymph nodes. And chances of reaction for this iodinated contrast media is there. It is a nausea, it is urticaria, it is a bronchospasm, and they can develop a really serious sequelae also. Anaphylactoid reactions are also possible, and they are rarely seen. Of course, death is also a chance that is there, and that should be kept in mind when we are trying to do that.
Iodinated contrast media has been implicated as being nephrotoxic and reported as inducing acute renal failure in 1 to 6% of unselected patient populations and up to 50% in high-risk patient populations. An isoosmolar or a low osmolar non-ionic contrast medium is preferred in patients with renal impairment and diabetes, and hydration before and after the examination may be required.
So very importantly, what we have to do for this is that you should have an idea about this iodinated contrast media. As we have seen, it is having chance of anaphylaxis. It can also be a nephrotoxic and reported of induced acute renal failure in 6% of the patients. 6% of the patients there can be renal failure also, and up to 50% of the high risk population in unselected patient population, and 50% in high risk population. If there is any problem, high risk population, it can lead to renal failure also. Isoosmolar or low osmolar non-ionic contrast medium is preferred. Non-ionic contrast medium is preferred in patients with renal impairment and diabetes, and hydration before the examination. What is it you have to do? Hydration has to be done before the examination, and whichever needed whenever after examination also you have to go for hydration. So very importantly, isoosmolar or hypoosmolar things should be given, especially non-ionic. Very important word you have to remember. Non-ionic thing you should be keeping in mind. Non-ionic thing only you should be giving it to the patient with this diabetes and the renal impairment problems.
CT scans can be displayed on different settings known as windows. Soft tissue and bone settings are routinely used in the head and neck. The scans of bony and cartilaginous structures, for example, the laryngeal cartilages in a patient with suspected laryngeal carcinoma, should also be reconstructed.
So you should be having in mind about this reconstruction displayed in different settings. So it is called as windows. So soft tissue window or bony window, these are the important things. Bony windows or soft tissue windows are the one which are there normally, which we keep, and the head and neck. So the scans of bone and cartilaginous structures, for example, laryngeal cartilages in a patient with suspected laryngeal carcinoma. So both bone and cartilage are useful for larynx. Cartilages present with suspected laryngeal carcinoma, they can be reconstructed in that manner.
Using a bony algorithm, which is helpful for demonstrating bone and cartilage involvement, coronal and sagittal reformats allow better evaluation of the skull base. The pulmonary parenchyma should be reviewed at the lung window setting if the chest is also being examined. Beam hardening artifact from dental amalgam can significantly degrade images of the oral cavity. Similar artifacts can also occur at bone soft tissue interfaces.
So bone algorithm, as you could see over here, so this bone algorithm has to be useful for things like demonstrating the bone and cartilage. So this is called a bone algorithm, like bone window. Bone algorithm is helpful for that, and coronal and sagittal reformations they help in the evaluation of the skull base. Coronal and sagittal reformations they help in the evaluation of the skull base. You should know the skull base, medulla oblongata, all these things can be so particular foramen magnum, all these things can be seen. So through which the pass the medulla oblongata, all these things can be helpful by bone algorithm. And pulmonary parenchyma so should be reviewed with the lung window settings. So lung window is useful for pulmonary parenchyma. So this lung window should be useful for pulmonary parenchyma when it is being used. Next, beam hardening artifact from dental amalgam can significantly degrade the images of the oral cavity. So beam hardening artifact is one important point for dental amalgam, especially in the oral cavity. They can also occur in bone and soft tissues sometimes. So that you should be keeping in mind. So which you could see the beam hardening artifact, especially very important for dental amalgam and computerized tomography. This picture is showing that you should keep it in mind. This. Next, focal erosion of the buccal surface of the left body of the mandible as per the standard Textbook shows this is the bony window. So bone window, you could see all these things. This one, focal erosion of this one. So this is one important point which you should be noting. Next, CT scan is over. Now we are going to come to the MRI, magnetic resonance.
Magnetic resonance imaging utilizes a homogeneous magnetic field, which in most clinical scanners ranges from 0.5 to 3 telsa in strength. Radio frequency pulses are used to excite the protons within the nuclei of the cells, and coils detect the changes in the magnetic field.
So very important. This is also very important even for the inter level, even MBBS level. You should be knowing this. Is MRI helpful for knowing? Useful is the magnetic field, homogeneous magnetic field. The scanners having the Tesla strength. This is a Tesla, not Telsa. Tesla strength of 0.5 to 3 Tesla. You should be keeping in mind 3 Tesla till 3 Tesla will be there. So we have got 1.5 M Tesla machine in our hospital, as you know that. And radio frequency pulses are used to excite the protons. So what is that is getting excited? So imagine that radio frequency pulse is a music, and the proton is you, me, and everybody. We get excited when we listen to the music, is it or not? So these protons get excited within the nuclei of the cells, and coils detect the changes in the magnetic field. So this hydrogen ions, that is H plus protons, they get excited and they do a lot of dance, and that is detected by the magnetic field. That is what is the concept of this MRI generally speaking.
The strong magnetic field requires stringent safety measures. All patients complete a questionnaire prior to the scanning. MRI is contraindicated in patients with cardiac pacemakers, cochlear implants, and metallic intraorbital foreign bodies.
So very importantly, everybody should be having this idea that safety measures are very important because it is a strong magnetic field. And a questionnaire should be completed. There will be a paper, even in our hospital, we give a paper to complete this one. And MRI is contraindicated, especially cardiac pacemakers, and that is heart people, and cochlear implant, that is ENT people, will be doing this. And then metallic orbital foreign bodies. All these things should be contraindicated. Any metal is there, you don't do that.
All patients in whom a metallic intraorbital foreign body is suspected require imaging of the orbits with conventional radiography to exclude a potential foreign body. Those patients who have iatrogenic foreign bodies in situ, such as surgical flips, embolization coils, vascular stents, prosthetic heart valves, and joint processes, may not be suitable for MRI.
So you know that metallic things you have to rule out by radiography. Conventional radiography, you have to go for radiography and then see the foreign body, especially in the orbit. If not, eyesight will be lost. Next, iatrogenic things such as surgical clips, embolization coils, vascular stents, prosthetic heart valves, and joint prosthesis all may be suitable for MRI.
It is important to establish the timing of surgery and whether the foreign body is ferromagnetic. Dental processes can also be problematic. The long bore of the conventional magnet has been reported to induce moderate to severe anxiety in up to 25% of patients undergoing examination, occasionally resulting in examination failure.
So especially when you have to do the timing of surgery, you have to keep that whether the foreign body is ferromagnetic or not. So paramagnetic, ferromagnetic, all these things as you know in physics. So that is ferromagnetic or not, you have to know that. And dental prosthesis also can be a headache. Sometimes they'll cause headache for us. You have to be removing them. And conventional magnet, if it is having a long bore, so it is inducing some amount of anxiety. So it also causes anxiety neurosis patients. 25% of the patients undergoing examination, especially it leads to movement artifacts, especially what is that called as movement artifacts.
MRI scanning is an interventionally configured magnet, may be appropriate in claustrophobic patients who fail examination in an unconventional magnet without sedation.
So claustrophobia, those who are fearing the closed spaces, they are very much important. It might be a failure in the examination. So it is an interventionally configured open magnet. As you should know that interventionally, wantedly, we are configuring the magnet, and then we are going to do that. Especially claustrophobia, it is very difficult without sedation.
Although CT is superior to MRI in assessment of cortical bone, MRI has superior soft tissue contrast compared to CT and allows true multiplanar imaging. Scan times are long, however, and require good patient cooperation as images are prone to movement artifact from coughing, swallowing, and dyspnea. An appropriate coil is placed over the region of interest and scans are performed in at least two orthogonal planes.
So you should be keeping in mind that MRI is for soft tissue. A very important point I'm trying to stress over here. Once again, I will annotate this one because we will be having an idea. So CT is for bone and MRI is for soft tissue, as you should be having in mind. And compared to CT and allows true multiplanar imaging. So multiplanar imaging is truly done in MRI. So multiplanar is truly done in MRI. Multiplanar imaging is truly done in MRI. That should be keeping in mind. And scan times are longer. It might take a very long time and requires patient cooperation. MRI needs patient cooperation. They are prone to movement artifact, as I already told you this one. It can be coughing, swallowing, or it can be dyspnea. The movement artifacts are very important as far as MRI is concerned. And appropriate coil is needed at the particular part to be done, and at least two orthogonal planes. You will be doing it in two orthogonal planes. Two orthogonal planes. And that should be kept in mind about these two orthogonal planes.
The most common sequences used in head and neck imaging are T1 weighted spine echo, T2 weighted spine echo, and spin echo and short toe inversion recovery (STIR). The T1 weight sequence displays anatomy well and is used to assess the lymph nodes and medullary bone involvement. T2 weighted sequences suppress the signal from fat, allowing easy demonstration of pathology, particularly the tumor.
So you should be keeping in mind, very importantly, very important one thing which we are going to see, T1 weighted and T2 weighted. So T1 weighted and T2 weighted. Be keeping in mind about this T1, T2 and short tau inversion recovery. So T1 weighted spin echo, T2 weighted spin echo and short tau inversion recovery. It is called a STIR sequence. Short tau inversion recovery. It is called a STIR sequence. So whatever T1 weighted, it displays the anatomy. T1 weighted, it displays the anatomy and helps in the lymph nodes and helps in the medullary bone. And T2 weighted images, so you should be having in mind about this T2 weighted images. So T2 weighted, they will be having signal form from the fat, allowing easy demonstration of pathology and particularly tumor. So you should be having in mind about T1 is anatomy, anatomy, anatomy. T1 is anatomy, 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 and T2 is about the pathology, pathology, pathology. So remember, T1 is anatomy, 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 especially lymph nodes and medullary bone. T2 is pathology, pathology, pathology. It suppresses the signals from the fat. You are drawing this now, so suppresses the signal from the fat. So fat is suppressed, allowing the easy demonstration of pathology and especially particularly the tumor. So you should be having in mind T1 anatomy, lymph nodes, medullary bone. T2 suppresses the signal from the fat for demonstration of pathology and particularly the tumor. I should keep it in mind about all these things.
Intravenous gadolinium chelates may be administered to assess for pathological enhancement in patients with suspected recurrent tumor following surgery and radiotherapy and for abnormal enhancement in involved nodes. It is also useful for assessing the perineural spread of the primary tumor.
So very important. Once again, I'm annotating only because of that. Gadolinium contrast especially is useful for, especially tumors like acoustic neuroma. And it is administered for pathological enhancement of the patients with suspected recurrent tumor following surgery and also radiotherapy and for abnormal enhancement in the involved nodes. So gadolinium contrast is for, as you know, you should think that gadolinium is very much useful for recurrence. So gadolinium is very much useful for recurrence. You should be keeping in mind about the recurrence. So about the recurrence. And also the radiotherapy and also nodes, as we have seen already. It helps in the PNS, that is perineural spread, like adenoid cystic carcinoma, as we have seen in the case of your parotid and the salivary glands. So perineural spread, the recurrence is number one, also perineural spread. What is the important point here is the gadolinium contrast. So gadolinium is also helpful in doing that recurrence, in seeing that recurrence, etc.
After contrast administration, fat suppressed T1 weighted images are used. Gadolinium is generally well tolerated and is safer than the iodinated CT contrast agents. However, it can also induce acute renal failure in patients with renal impairment. Nephrogenic system fibrosis is also now recognized as a serious late complication following administration of gadolinium based contrast to patients with dialysis dependent renal failure.
So what you should keep it in mind, what are the complications of this gadolinium is something which is now to be answered. So this contrast administration will help in fat suppressed T1. So fat suppressed T1 is taken after this contrast administration. Gadolinium is well tolerated and safer than the iodinated contrast, CT contrast agents. So gadolinium is safer than the iodinated CT contrast agents. However, it can induce the acute renal failure also, very importantly, with renal impairment. So better not give in renal impairment patients. This acute renal failure is also a possibility. Next, one more important point is nephrogenic systemic fibrosis. Nephrogenic systemic fibrosis is a recognized serious late complication. Nephrogenic systemic fibrosis is a late complication following administration of gadolinium based contrast to the patient with dialysis dependent. One important point. So gadolinium contrast can cause nephrogenic systemic fibrosis. Nephrogenic systemic fibrosis. Gadolinium can cause nephrogenic systemic fibrosis. So as you could see, T2 weighted and T1 weighted. So T2 weighted, A is the T2 weighted image and B is the T1 weighted image. As you could see here, demonstrating signal loss around a metallic dental bridge. So T2 weighted and this is T1 weighted. So MRI angiography of the distal leg vessels. You could see the distal leg vessels. MRI angiography is one more application of MRI. So hello.
Sir, చెప్పండి sir.
Okay. I think start.
Okay, sir. Magnetic resonance angiography. Magnetic resonance angiography can demonstrate flow within vessels and evaluate arterial stenosis. All patients in whom a fibula-free flap graft would be the most appropriate method of facial reconstruction, even if they have no evidence of peripheral vascular disease and no history of intermittent claudication, ideally should have pre-operative assessment of the leg vessels with an MR angiography.
So very importantly, everybody should undergo MR angiography. This is very important. And wherein you can see the flow within the vessels. What you see is the flow. How is the blood flowing within the blood vessels? That is what is seen in the MR angiography. And it is also helping in evaluation of the arterial stenosis. So how is the arterial stenosis? You are able to see that. And especially for fibula free flap graft, you are going to do with the for a facial reconstruction. Even if they have no evidence of peripheral vascular disease and no history of intermittent claudication, ideally should have preoperative assessment. So whatever, whether there is intermittent claudication there or not, whether peripheral vascular disease there or not, you have to go for MR angiography. It is called as MRA. Very importantly, nowadays done for many of the things, many of the patients, especially for this pre-flaps, etc.
This provides an anatomical roadmap of the arterial tree and allows confirmation that the remaining vessels will adequately supply the foot once the flap has been harvested.
So as you could see, confirmation that remaining vessels will adequately supply the foot. Whatever is the remnant, that will be supplying the foot.
Nuclear medicine. Nuclear medicine studies utilizes radioactive isotopes that are often bound to physiological molecules. These investigations predominantly evaluate the function and physiology, anatomical detail, and spatial resolution are poor compared to other imaging modalities.
Especially this nuclear medicine is the latest technology that we are using the radioactive isotopes and they are bound to physiological molecules. So radioactive isotopes are bound to physiological molecules. Very important. Two things that are being done is radioactive isotopes are being bound to physiological molecules. So it's just like, for example, so this is the vehicle that person is there. So this is the radioactive isotope that is there. Along with that, a physiological molecule also will be sitting along with that. So two will be. So this is radioactive isotope, Ri. So radioactive isotope, and this is the physiological molecule. Physiological molecule. These two will be sitting together, and then they'll be going and riding forward. It's called as radio pharmaceuticals. You should keep it in mind about the radio pharmaceuticals. So they evaluate the function and physiology. So whereas CT scan and MRI, these will be helpful for anatomy, and this will be helpful for physiology, especially this is physiological. So whatever is the function, that will be knowing that. So anatomical detail and later resolution and poor compared to the imaging models. Of course, physiology is more commonly dominated by than by anatomy. You should keep it in mind about that one. So you should be having information about that one.
Radioisotope whole body bone scanning with the conventional isotope technetium-99m methylene diphosphonate has a high sensitivity but a poor specificity in demonstrating bony metastatic disease in patients and can be used to assess for local bone invasion. However, 99MTC single photon emission computed tomography, that is SPECT, has higher specificity than the conventional bone scanning and can also be used to improve the accuracy of predicting the local bone invasion in patients with oral cavity tumors.
So as you could see here, you should have in mind about this radioactive isotope whole body bone scanning. Whole body bone scanning. This should be kept in mind. So what is that conventional technetium 99M? Technetium 99M, you will be doing that in the scan. That is nothing but methylene diphosphonate. Technetium 99M methylene diphosphonate. Methylene diphosphonate has got a high sensitivity. Even the minutest also can be seen with this methylene diphosphonate. Even the minutest, that is why it is having high sensitivity. So sensitivity is there, high sensitivity is there, but poor specificity. You don't know exactly where it is located, but high sensitivity is there. So it helps us in knowing the bony metastasis, number one, and also helpful in local bone invasion. Bony metastasis and also helpful in local bone invasion. Bony metastasis and local bone invasion. However, other than that, nowadays it is a SPECT scan. So single photon emission computerized tomography along with technetium 99M. So diphosphonate, methylene diphosphonate, technetium 99M SPECT is also got higher specificity than conventional bone scanning and accuracy in local bone invasion. You could see the local bone invasion can be seen, especially in the oral cavity tumors. What you have to do is technetium 99M SPECT, technetium 99M, technetium SPECT scan is helpful for this particular uh, oral cavity tumors. That is one thing which is very important, very important. So technetium 99M SPECT scan.
Suspected post-operative pulmonary emboli can be confirmed using a ventilation perfusion scan, that is a VQ scan. These utilize 99 MTC labeled macro-aggregated albumin to demonstrate blood flow within the pulmonary capillary network and either xenon 127 gas or nebulized 99 MTC to evaluate the ventilation of the lungs.
So this is also very important. So I'm trying to annotate this one also. When you have this ventilation perfusion scan, VQ scan, it is called as for pulmonary emboli. Especially you'll be using it for post-operative pulmonary emboli. So post-operative pulmonary emboli, you will be doing the ventilation perfusion scan. Very important. So they utilize once again technetium 99M macroaggregated albumin, especially to demonstrate the flow within the pulmonary capillary network. To demonstrate the flow within the pulmonary capillary network, and either xenon 127 gas or technetium 99M, xenon 127 gas or technetium 99M nebulized one to evaluate the ventilation of the lungs. So this is something called as ventilation perfusion scan. Xenon 127 or technetium 99M can be helpful. Will help for macro aggregated things. Macro aggregated things that you can do that.
Iodine-based isotopes are used in the assessment and treatment of thyroid disease. Functioning thyroid nodule takes up iodine 131.
So once again, technetium 99M over xenon 127 over. Now it is iodine-based isotopes. When you take iodine-based isotopes, they are helpful for number one is the assessment. You should keep it in mind. Number two is the treatment. You should be keeping it in mind. So you have to assess it and also treat it. You see whether the iodine uptake is present or not. Number one. Number two is you have to treat it. That is by ablation. So functioning thyroid nodule. So any thyroid is there. What is the function? Okay, like some of the people they take the bribe. So this iodine takes the bribe of iodine. This thyroid takes the bribe of iodine 131.
Positron emission tomography. Positron emission tomography is an imaging technique utilizing radioisotopes that emit positrons. Fluorine labeled deoxyglucose, a glucose analog, is the isotope used for 98% of PET imaging. Like other forms of nuclear medicine, PET imaging provides functional information.
So same thing, PET scan. So this PET scan very important. It also utilizes the radioisotopes that emit the positrons. So they emit the positrons, especially the fluorine labeled 18 FDG. Very important. This is very important for entrance point of view also. 18 FDG, which is a glucose analog. So 18 FDG, which is a glucose analog, is the isotope used for 98% of the scans. So in other forms of nuclear medicine, PET scan provides functional information. You should be keeping in mind that this is a physiological one, therefore functions are notified. Along with PET, if you are doing the CT scan, it is called as PET CT. Along with PET, you are doing MRI, PET MRI. You can just say that it helps in the function.
PET scan alone is relatively poor. CT or MRI is necessary. Combined in line, PET CT scanners allow accurate co-registration of the functional information from the PET scan and the anatomical information from a non-contrasted, relatively low-dose CT scan. PET CT has a higher accuracy of depicting cancer and evaluating its anatomical localization than PET alone.
So as already told, this one you are able to see that relatively poor along with the help of CT and MRI you should be helping. I told you the bike example. So like your physiological functions by PET scan and anatomical functions by CT and MRI it is useful for. Combined in line with PET scanners allow accurate co-registration of the functional information from the PET scan and anatomical information from the contrasted relatively low dose CT scan. So you know that the accuracy of detecting the cancer is high with along with CT.
False positive results in PET-CT can occur due to normal physiological uptake in tissues such as the tonsils and the salivary glands. Tracer also accumulates in metabolically active tissues and in muscles secondary to contraction such as phonation during the uptake phase.
Very important, you should keep it in mind about these tonsils and also your salivary glands. So physiological uptake can be there in tonsils and salivary glands and also in muscles, and it is like phonation like in the uptake phase. You should have it in the uptake phase. You will be having the muscles of the vocal cord. So you'll be having in mind. The vocal cords can get, we have a lot of concentration over there.
False negative results are seen in tumors with low metabolic activity, such as the salivary gland tumors, in necrotic tumor, and in patients who have undergone recent treatment, particularly PET-CT performed within 4 months of radiation therapy.
So very importantly, if it is like in a salivary gland, it is not of much use. So you should keep it in mind about the salivary glands. Salivary glands not of much use because and also in the necrotic gland. So very low metabolic activity will be there. So there is a low metabolic activity. So it is not much very much useful, especially even in the 4 months of radiation therapy. So 4 months of radiation therapy also. So you will be having nothing much of use in this particular situation. So recent radiotherapy PET scan is not much useful. So keeping in mind.
In patients with suspected head and neck cancer, 18F FDG PET scan is a valuable tool in the preoperative stage of head and neck tumor, as it can evaluate regional lymph node metastasis, detect distant metastasis, and identify unsuspected synchronous primary lesions.
Very importantly, 18 FDG FDG PET scan is very much useful for head and neck cancers, especially to evaluate the regional lymph node metastasis. Regional lymph node metastasis can be evaluated by that. And we can detect the distant metastasis also. We can see the synchronous primary, that is, along with that, any other tumor is there.
It is also useful in evaluating patients with proven pathological cervical adenopathy, but an unknown primary lesion. However, 18F FDG PET scan rarely provides additional information regarding the T stage of tumor over initial clinical evaluation and cross-sectional imaging with CT and MRI.
So also helps in ruling out the cervical lymphadenopathy. So with the proven cervical lymphadenopathy, you can evaluate unknown primary. You can see, and you can see the FDG PET helps in the T stage of the tumor. Helps in the understanding the T stage of the tumor. Helps in the cross-sectioning imaging along with CT and MRI.
18F FDG PET CT is useful in post-op patients to monitor tumor recurrence and after chemoradiotherapy. It can also be used to evaluate the response of lesion to treatment and aid selection of patients for subsequent neck dissection or salvage surgery.
So you should be knowing it in the post-operative patient also. You can do it for tumor recurrence and chemoradiotherapy. After that, how much is the tumor you can see, and response of the lesions to the treatment, and selection of the patients for subsequent neck dissection or salvage surgery. So PET scan is very important.
Nasopharyngeal cancer. Squamous cell carcinoma accounts for about 70% of superficial malignant tumors in the nasopharynx. Lymphomas account for about 20% with tumors such as the adenocarcinoma, rhabdomyosarcoma, adenoid cystic carcinoma, melanoma, plastocytoma, fibrosarcoma, and carcinosarcoma, making the remainder.
So when you take the NPC, it is a squamous cell carcinoma which accounts for 70%, especially the superficial malignant tumors in the nasopharynx. So superficial malignant tumors very important. Next is lymphomas, that is 20%. Rest all are adenocarcinoma, rhabdomyosarcoma, adenoid cystic carcinoma, melanoma, plasmacytoma, fibrosarcoma, carcinosarcoma, etc.
Imaging should aim to provide an assessment of the pattern of spread of the tumor, especially into areas not easily examined clinically, that is deep extension and extension superior to the skull base and beyond.
So you should be seeing about a skull base and beyond, where is it extending, or the deep extension which cannot be seen clinically.
The fossa of Rosenmuller is a common site of origin of the nasopharyngeal cancer. Submucosal lesion will not be detected endoscopically, and the MRI with its superior soft tissue contrast is the best suited imaging modality to detect these lesions. Both CT and MRI will detect the skull base invasion.
So you should know about CT and MRI, especially MRI soft tissue contrast is the best suited modality for this.
CT scan detects early cortical involvement better than the MRI, but MRI is better than CT for the delineation of the marrow involvement. It may be necessary to perform both in some patients to accurately determine the disease extent. The pharyngobasilar fascia provides a barrier to disease, but once this is breached, tumor can invade the skull base directly. High resolution T1 weighted MR images are used to examine the pharyngobasilar fascia, which appears as a continuous low signal intensity linear structure.
So as you know, this pharyngobasilar fascia, that is PBF, and try to annotate this one. Pharyngobasilar fascia is very important for us to be keeping in mind. This pharyngobasilar fascia, whether it is breached or not, it will help spread towards the skull base. So pharyngobasilar fascia is a good barrier to the disease. It will prevent the skull base erosion. And you can go for CT scan, early cortical involvement, MRI for bone marrow. MRI is for the bone marrow involvement. So some patients we have to go for that. And high resolution T1 weighted MR images can be used to see the pharyngobasilar fascia. T1 MRI it can be useful for pharyngobasilar fascia, and it appears as a low signal intensity in this linear structure. Low signal intensity in the linear structure. As you could see, all those things. Low signal intensity in that situation. So in this FDG pit, we have seen that a tracer can be seen over here, FDG pit. So as you could see here, all these are pictures. Every tracer uptake within the pathological right neck nodes. So you should see that neck nodes, unknown primary, you could see that here. And lateral extension into the deeper structures of the nasopharynx can occur via the sinus of Morgagni. That is, we are dealing with the nasopharyngeal carcinoma. Once again, the pictures are very different previously. Lateral extension with the sinus of Morgagni should be keeping in mind. A natural facial defect sited in the superolateral wall of the nasopharynx, which allows the passage of eustachian tube and levator vellae peritoneum. So this is the sinus of Morgagni, which helps in the passage of this sinus of Morgagni, helping in the passage. The sinus of Morgagni is very important as far as the nasopharyngeal is concerned. It helps in the lateral extension of the tumor. So especially a facial defect, it can be called as a facial defect. The superolateral wall of the nasopharynx. So when you take this nasopharynx like this, you can draw it like the superolateral wall is this part. You can see the fossa of procermolar over here, and superolaterally you have got the sinus of Morgagni. So sinus of Morgagni superolaterally helps in the passage of eustachian tube and levator vellae peritoneum, as we know that. So these two things are to be kept in mind while doing that. So sagittal T1 weighted images and T2 weighted images demonstrating bulky nasopharyngeal tumor with direct extension into the flavus. You could see this tumor with direct extension into the flavus, that is sloping part of entire part of the skull base. So nasopharyngeal tumor, as you could see once again here, large nasopharyngeal tumor invading the nasal cavity with loss of laryngobasilar fascia and obstruction of the left and the resulting left mastoid air. This is opacification of mastoid air cells. This is a normal one. This is opacification of mastoid air cells. And large nasopharyngeal tumor on the same thing. And tumor can gain access toward the masticator space and pre and post styloid parapharyngeal spaces also. This can result in involvement of third division of the fifth cranial nerve. The mandibular division can be occurring if it is gaining access to the masticator space, pre and post styloid parapharyngeal spaces. Retrograde perineural spread to the skull base also can occur. Perineural spread is also there in this one. The common sites of skull base invasion are petroclinoid fissure and foramen lacerum. So common sites of skull base involvement are petroclinoid fissure and foramen lacerum. So foramen lacerum, petroclinoid fissure and foramen lacerum. This can result in internal carotid artery encasement, extension into the cavernous sinus also. Internal carotid artery encasement and extension into the cavernous sinus also. So perineural spread, which can be seen, we have already seen this point before also. Perineural spread can be seen with T1 suppression MRI scans. So T1 weighted fat suppression MRI scan. Perineural spread can be T1 suppression fat suppression scan along with gadolinium contrast. So perineural spread, as you could see here, with fat suppression, gadolinium contrast. This is seen as an expansion and added enhancement of the nerve. So you could see this enhancement, the nerve is getting enhanced in this particular point. Tumor may also directly invade the skull base and involve the foramen ovale also. Occult submucosal spread may occur in a caudal direction, and inferior limit of the disease is often visualized on the coronal images. So inferiorly you can see the surgeon's images, that is coronal images. Nodal disease is extremely common and is present
85 to 90%.
Yeah, it's almost 90%. The patient presents with nodal disease only, and it is likely to be in the bilateral in a half of the patients. Almost bilateral. Bulky nodes, the patient presents with bulky nodes. So retropharyngeal nodes are the first one which are affected, but level 2 nodes may be involved without retropharyngeal nodal disease. So retropharyngeal nodes, you should keep it in mind. So MRI image has been shown to have a higher accuracy, especially more than 92% than PET for the diagnosis of residual or recurrent disease following treatment of the primary site. So for nasopharynx, especially you go for MRI image only. The combined use of both modalities will be helpful for restaging. I think this ends the PowerPoint here. So we have completed almost till this level. Thank you very much for watching ENT student for this particular PowerPoint on radiology.